So currently we have for transplant eligible patients Daratumumab, Bortezomib, Thalidomide and Dexamethasone combination, which we give to induce remission followed by transplant, consolidation with Daratumumab, Bortezomib, Thalidomide, Dexamethasone and then Lenalidomide maintenance. So this is a sequence that is made up of an induction regimen from one trial called the Cassiopeia trial, and the lenalidomide maintenance came from a completely different study, which was the UK's Myeloma 11 study, which has the largest experience of lenalidomide maintenance. So this particular cassette is helpful in keeping myeloma patients in remission and converting a large proportion of patients to MRD negativity. But we think that we can do even better than this, because the recent data from the PERSEUS trial shows that using a combination of Daratumumab, Bortezomib, Lenalidomide, Dexamethasone, followed by Daratumumab, Lenalidomide maintenance, will probably achieve a larger proportion of MRD negativity and therefore a significantly improved progression-free survival for patients. So we are looking to offer this particular treatment for patients in the future. The current RADAR trial is providing a different sort of nuance to the upfront transplant eligible patients, where we are using the genetic risk at diagnosis to decide how much therapy patients get at the time of induction and also after transplant. So for standard risk patients, we don't give a CD38 antibody during induction, and when patients have had a transplant, if they're MRD negative, then we give them a CD38 antibody for a duration of time and then randomize to stop or continue. But for transplant eligible patients who are MRD positive and are standard risk, then we're trying to convert them to MRD negativity. So a lot is changing with new therapies, but also nuances will appear based on genetic risk as well as MRD as a biomarker post-transplant.